Welcome to the weekly Neurology Deep Dive. Today we're diving into a recent study that puts two advanced treatments for generalized myasthenia gravis head-to-head.
That's right. We're looking at C5 complement inhibitors versus the newer neonatal Fc receptor, or FcRn, antagonists.
And just a reminder, this deep dive is purely for educational purposes. It's really a summary. For the full picture, you absolutely need to read the original publication.
Definitely. The information is aimed at neurologists, focusing on practical points for daily clinical practice.
Our goal today is to unpack the findings from a specific paper, C5 complement inhibition versus FcRn modulation in generalized myasthenia gravis. We'll look at effectiveness, safety, basically how they stacked up in the real world.
Okay, so maybe a quick refresher on MG. It's that autoimmune disorder hitting the neuromuscular junction. And, well, despite standard immunosuppression, some patients still struggle.
Which is where these newer therapies come in.
Exactly. You have the C5 inhibitors, eculizumab and ravulizumab, targeting the complement cascade, and then the FcRn antagonists like efgartigimod, which work differently, reducing those disease-causing antibody levels.
Both seem promising, but there hasn't been much direct comparison, especially outside of, strict clinical trials.
Right, and that's the gap this study aimed to fill. It wanted to directly compare C5 inhibitors and FcRn antagonists' effectiveness and safety in a real-world setting.
How did they do it?
It was a retrospective study looking back at patient data from 8 specialized MG centers in Germany. Quite a few patients, 153 in total.
And to make the comparison fair, given its retrospective.
They use propensity score matching, or PSM. This helps balance the groups, letting them compare outcomes within the first 6 months of treatment more reliably.
Makes sense. So who were the patients in the study?
Overall, there were 106 patients on C5 inhibitors, 26 on eculizumab, and 80 on the longer-acting ravulizumab, and 47 patients who received efgartigimod.
And the criteria?
All had confirmed generalized MG, age 18 or older. Importantly, for eculizumab, patients needed to have anti-acetylcholine receptor antibody-positive MG that was refractory to prior treatments. That's a key point.
Okay. And for the others?
Efgartigimod was used as an add-on for generalized MG, and ravulizumab also as an add-on, specifically for anti-AChR-positive generalized MG.
And they were likely on other standard treatments, too.
Oh, yes. Standard therapy like corticosteroids, maybe thymectomy, history, pyridostigmine, other immunosuppressants, the usual background treatments.
So looking at the whole group initially before matching, what did they find?
Well, the good news was both strategies led to rapid clinical improvements. Patients generally got better, and they could significantly reduce their prednisolone doses.
I sense a but coming.
Yes, but it wasn't universal. Depending on the measure used, QMG or MG-ADL scores somewhere between 20% and almost 50% of patients still had an insufficient response.
That's a substantial portion. Any major safety flags in the overall cohort?
No, encouragingly, no new safety concerns popped up in this initial analysis of the whole group.
Okay, so then they did the propensity score matching to get a cleaner comparison. What groups did they compare?
They focused the main comparison on ravulizumab versus efgartigimod, creating 2 matched groups of 40 patients each.
And the primary endpoint, how did they compare there?
The primary outcome was the reduction in the MG activities of daily living, the MG-ADL score. And the finding was they were comparable. No significant difference between ravulizumab and efgartigimod.
Can you give us the numbers on that?
Sure. The mean reduction in MG-ADL was 4.7 points for the ravulizumab group and 4.3 points for the efgartigimod group. Statistically very similar. The p-value was 0.637.
And other measures? Secondary outcomes?
Also showed pretty similar results. For instance, the mean maximum reduction in the quantitative MG, or QMG score, was 5.4 points for ravulizumab and 5.8 for efgartigimod. Again, no significant difference there either.
What about achieving that patient-acceptable symptom state, or PASS?
Right. Using the MG-ADL threshold of 2 or less, about 28% of ravulizumab patients and 25% of efgartigimod patients hit that mark. Very close.
And using the QMG threshold, I think it's 7 or less.
Yes, QMG 7. There, it was 50% for ravulizumab and 55% for efgartigimod. Again, statistically comparable.
Did they see similar trends with reducing background meds in these matched groups?
They did. Prednisolone dose reductions were comparable at 5.3 milligrams per day, average reduction for ravulizumab, 6.7 for efgartigimod.
Erdodestigmine.
Also comparable reductions. Roughly 57 milligrams per day for ravulizumab and 37 for efgartigimod. So similar impact on background therapy needs.
Let's talk safety in the matched groups, ravulizumab versus efgartigimod. Any differences?
Overall, the safety profiles look similar.
Yeah.
But there was one notable exception. cholinergic side effects.
Oh, what did they find there?
A significantly higher rate in the ravulizumab group, with about 23% of patients experiencing them, compared to, well, 0% in the efgartigimod group in this matched analysis. That difference was statistically significant.
It's interesting. What about things like exacerbations or crises?
Those rates were comparable. Myasthenic exacerbations occurred in about 18% of ravulizumab patients versus 20% of efgartigimod patients. Crises were 5% versus roughly 13%, respectively. Not statistically different.
The study also did another comparison, right? The F-Gartimod versus the whole C5 inhibitor group.
Yes, they did a secondary matched analysis comparing efgartigimod to the combined C5IT group, so including both eculizumab and ravulizumab. They adjusted the matching for that eculizumab refractoriness criteria.
And the result of that comparison.
Same story, essentially. No significant differences found in efficacy or safety between efgartigimod and the overall C5 inhibitor group in that matched analysis either.
So pulling it all together, what's the main message for neurologists listening?
I think the key takeaway from this real-world data is that C5 inhibition, specifically ravulizumab, and FcRn antagonism with efgartigimod, seem to offer comparable levels of efficacy and safety for treating generalized MG.
Which is useful information when you're personalizing treatment plans.
Absolutely. It gives you more data to consider when choosing between these advanced therapies. However, there's that important caveat.
The insufficient responders.
Exactly. We can't forget that a significant chunk of patients, 20 to nearly 50%, depending on the measure, didn't get the response we'd hoped for with either strategy.
Which clearly highlights the need for, well, more options.
Precisely. There's still an unmet need, and research into further therapeutic approaches is definitely still warranted.
So that wraps up our deep dive into this comparative study of C5 inhibition and FcRn antagonism in generalized MG. The real-world findings suggest both are valuable options with similar outcomes for many.
And just to reiterate, this was an educational summary focused on the clinical data points. For a thorough understanding, please do check out the original research paper itself.
The data showing comparable effectiveness and safety gives you, the clinician, valuable insights for those treatment discussions. But that observation about the substantial group with insufficient response really underscores the ongoing search for better and perhaps different ways to manage generalized MG.
So as you reflect on this real-world evidence, how does it mesh with the clinical trial data you've seen? And perhaps more importantly, how might findings like these influence your approach when you're sitting down with your next patient with generalized MG? Something to consider for your practice.